Okay, well, Dr. Shore, Jeremy, Jake, if he's on, thank you very much for inviting me today. And I'm going to talk about non-CPAP treatments for sleep apnea. And I'll show my email at the end, but if you have any questions about this, please let me know. By way of disclosures, ResMed, which I think probably many of you know, makes CPAP devices. They've given money to our sleep medicine clinic. None of that goes directly to me. And here's what I'll talk about today. So I have about 45 minutes worth of material. I'm going to give a really brief introduction to obstructive sleep apnea. And then really the rest of the talk will be in thirds, really how good is CPAP anyway? I think Sharon and others may have talked a little bit about controversies in sleep apnea and how you manage it with CPAP, but all the non-PAP therapies, non-positive airway pressure therapies, you have to compare them to CPAP, so you have to know how good CPAP is. And then I'll talk about non-PAP therapies. This is not meant to be an exhaustive list. I have some references there, but it's enough to give you a little bit of the landscape out there. And then I'll talk a little bit about some of the research that we've done to try to help predict who's going to do well with non-PAP therapies. And that'll be a little bit deeper dive into sleep apnea pathogenesis. So I think, I love the Netter drawings, but if you think about sleep apnea pathophysiology, it's basically that you have collapse of the upper airway at some level, whether that's the soft palate behind the tongue or the epiglottis. And so even though this is kind of the life cycle of an obstructive apnea, it all starts with having inadequate anatomy. Not a problem when you're awake, right, because you have muscles that hold the upper airway open. But as you go to sleep, you lose the upper airway muscles, the airway collapses, and people struggle to breathe, eventually leading to an arousal, which is a life-saving maneuver, gets air in and out, but leads to cardiovascular sequelae and sleep fragmentation, so people feel tired. And I'll come back to this later. Probably some of you are familiar with this, but just, again, very brief background for obstructive sleep apnea. How common is obstructive sleep apnea? These are data from Adam Benjefeld, who works for ResMed, but so might be a little biased in terms of estimating the number of people that might need to be treated with CPAP, but a number of very respected and worldwide researchers in sleep apnea. There have been a number of definitions of what meets criteria for obstructive sleep apnea, but if you look at the 2012 scoring rules, if you take all people who have more than mild sleep apnea, there's close to 1 billion people worldwide. This was a study where in some countries, there are prevalence estimates. So let's say Switzerland, we have good estimates of how common sleep apnea is. And these authors tried to apply those data to other countries that, let's say, looked like Switzerland. And they tried to sort of populate a map of the entire world. So 1 billion people might have sleep apnea if you use a mild criteria. If you look at those with an apnea-hypopnea index more than 15, moderate to severe sleep apnea, you're down to a paltry 425 million. In the United States, again, this means a lot of people have obstructive sleep apnea. So this is going to sound weird since I'm talking about treatments for sleep apnea that don't involve CPAP, but you really need to think, does this patient need to have their sleep apnea treated? And certainly when I was a pulmonary critical care fellow, there was nothing less satisfying than trying to treat people without symptoms with apnea-hypopnea indices of about 6 or 7 per hour. Not very satisfactory. So, think about whether or not a patient needs to have their sleep apnea treated. And, this has been sort of talked a little bit about in the literature in the last few years. So Li-Xuan Yi, when she was at Penn, published this article in ERJ. And the idea is that not every patient experiences sleep apnea the same way. And so you might have people who have disturbed sleep. They actually can't fall asleep or they can't stay asleep. You have excessively daytime sleepy people who fall asleep all the time. And then you have other people who are minimally symptomatic. And so if you don't have a lot of symptoms, no matter what treatment you select, you may actually not improve people very much. So again, that's just a very brief overview of obstructive sleep apnea. But once you've made the decision, yes, my patient has symptoms or they have comorbidities, I want to treat sleep apnea, then you get into the landscape of what is out there. So I'm just going to spend about 10 minutes on how good is CPAP anyway. And some of you may know this, but I think that CPAP gets a bad rap in part because we actually know how much people are using it. I have news for you. All those inhalers that you're prescribing, your patients don't use them the way they're supposed to. Same with antibiotics. Doctors are no better than mere mortal patients. So adherence is a real issue for all therapies that we prescribe. It's just that CPAP has an odometer on it that tells you what's going on. So many times when you talk about continuous positive airway pressure or CPAP, I like this picture because that's the sort of freak out face that many of your patients make. I will say that in years past, many more people had this kind of reaction to CPAP. Oh, is that mask thing? Whereas now, many people also will say, yeah, I talked to a buddy of mine and CPAP really gave him back his life. So I think there's a more nuanced appreciation of CPAP out there. CPAP works as a pneumatic splint. So I showed you the collapse before. Again, we're just trying to create space for air to flow in and out. If we could put a plastic stent or a metal stent, be like cardiologists, we would do that, but that would obviously mess up a lot of other parts of the upper airway. Not going to go very briefly into what CPAP does. Again, I think other people or other sessions in the FTS have gone over this, but I'm showing these studies just to give you an idea of the breadth and depth of studies that are there with CPAP. And the problem is, as I'll mention in the future, many of the non-CPAP therapies, we don't have this wealth of data. So this study by Jose Marin in The Lancet 2005 looked at months of follow-up. So this is 12 years of follow-up, and then on the y-axis, cardiovascular fatalities. And what's nice is there's a nice dose response between controls, people who snore, mild sleep apnea, and then severe sleep apnea in terms of worsening outcomes. And if you use CPAP, these aren't randomized data, but the use of CPAP got you back down to kind of a non-sleep apnea risks. We have data about blood pressure in CPAP. This study by Becker and colleagues is probably the most dramatic effect of CPAP with a 10 millimeter mercury drop in blood pressure. Again, not going to go into this, but Sidney Montesi, when we were in Boston together, had this meta-analysis, and just look at the number of studies here that have looked at CPAP and blood pressure. So, it turns out the effect is probably pretty modest, just a few millimeters of mercury, but many parameters for CPAP, we have a lot of data. For non-PAP therapies, we have really a paucity of data. We also know things about cognitive performance. This is a kind of scary study. If you give people a driving simulator and you measure how many obstacles they hit in 30 minutes before CPAP, now these are small numbers, but you can see people hit about 30 obstacles in that half hour. I haven't taken the test. I don't know how hard this is, but the trick is after you give them CPAP, they get better. So again, we know quite a bit about how CPAP affects cardiovascular outcomes, cognitive performance. Apparently, you can reduce your golf handicap by 1 stroke. Again, people have looked at many different outcomes. In terms of dose response, and this will be true for non-PAP therapies as well, the more you use CPAP, the more benefit people generally experience from that. So this is a study by Terry Weaver and colleagues, and they have different parameters here. The FOSQ is sort of a sleep quality of life questionnaire, Epworth sleepiness scale, or ESS. I'll be commenting on this quite a bit. It's a subjective sleepiness score. And then MSLT, multiple sleep latency test, is an objective measure of how quickly people fall asleep. And you can see, as people use CPAP more per night, things like objective sleepiness, quality of life, and sleepiness all get better and get it within, more people achieve a normal value. Although, many people with sleep apnea still feel quite tired. And so these are the people that you might end up prescribing stimulants to, but that's sort of another topic. Now, like all things related to adherence, if you ask people, hey, how much do you use your CPAP? About 75% of people say, yeah, I use it all the time. But when you actually do a download from the device, you find that the reality is usually lower than that. And there have been some data, and I'll show you that if you really kind of help people with intensive compliance or adherence programs, then you can actually boost that number. So let me show you some of those data. What's really interesting is that if you think about it, CPAP devices are one of the most commonly worn activity trackers or wearables out there in the country today. So, some of you probably have Fitbits, but actually the CPAP databases are really tremendous. So this is a study. Peter Sestouli is a sleep doctor from Sydney. I'll mention some of his work. He's done a lot with oral appliances. But using the ResMed AirView database for 3 years, they looked at all the CPAP setups, and this included 2.6 million patients. Now, we don't know a lot about these patients in terms of their other comorbidities, but they were set up with CPAP, and of the people who were set up with CPAP, 75% of them met Medicare criteria. So that means more than 4 hours per night on more than 70% of nights. Now, this is 75% of people who are set up. These are people that not just had a prescription, not just a doctor told them they needed CPAP. They said, yes, I want CPAP, and they had to run it for at least an hour. To have fair and balanced news, if that was MSNBC, this is Fox News or Coke and Pepsi. But the Philips Respironics is the other big company that makes CPAP. They also have their database. And so Sai Parthasarathy from Arizona looked at a couple 100,000 CPAP users to look at adherence in their cohort. He did a little bit different kind of thing. He looked at how socioeconomic status impacts adherence. And on the left here, not surprisingly, as you move up in socioeconomic status, adherence is better, meeting about that 50% Medicare-defined adherence. On the right side, a little more optimism here. He looked at all income groups, but by time period. And you can see that as the years go by, with advances either in PAP therapy or other changes in practice, you can see that year on year, the adherence is going up. So again, I think 50% is an often quoted number in the literature about how much people use CPAP. The number is probably a little bit higher than that. Why might that be? I think you know this, but there's been some changes in interfaces. I used to hear a lot of complaints about claustrophobia. That has gone away quite a bit. We often use auto-titrating or adjustable PAP instead of fixed pressure CPAP. Not any great data that makes a difference in adherence, yet describing that to patients really, that's a selling point, like, oh, this must be better than when I last tried CPAP. One thing that has made a very big difference, though, and again, many of you may know this, is that we can monitor patients better. And what's really interesting is on the right side of this slide here, this is a picture from an app that one of the devices has. So, basically people get a score and they get feedback. How much did they use their device last night? Was the mask seated well? Did my AHI get better? And, some people are just competitive and they see that they have a B here and they want an A or an A+. So with these kinds of interventions, and this is published, but you can give people feedback. It can be relatively automated, and you can improve adherence to CPAP. And so using these APE, active patient engagement tools versus usual care management, more people use their CPAP for more hours per night. So, again, this is not a lecture about CPAP, but I think for many patients, CPAP is going to be first-line therapy. You can always do a therapeutic trial, see how people like it. If people are very symptomatic, if they have severe comorbidities, or if they have severe disease, either by AHI or substantial oxygen desaturations, you're going to need to at least think about a trial of CPAP. Now, the reason that I've gone over this is that when we talk about non-PAP therapies, the bar is pretty high. PAP works, as long as people can use it, and the adherence is getting better. So I think that the assumptions about non-PAP therapies, which we'll go through in some of the lecture here or some of the discussion, is that the adherence for non-PAP therapies is going to be better than CPAP, and we'll explore whether or not that's true. The other thing is that non-PAP therapies need to be as effective as CPAP, or at least kind of this effective AHI needs to be as good as CPAP. And by what I mean by that is that if CPAP really treats sleep apnea well, but people only use it half the time, maybe you can get by with a therapy that works pretty good but not perfect most of the time. When we talk about effectiveness, as I'll go through, most of the time people have measured things like apnea-hypopnea index, maybe some subjective sleepiness, and very rarely blood pressure or other outcomes. We don't have as much as what we know with CPAP. Certainly providing CPAP, around the globe might be expensive. Patients may not have access to reliable electricity. So, maybe some of these therapies are cheaper. And then again, more, always looking for more patient-centric devices. So telling a young person, it's not uncommon to hear, boy, CPAP is really not a very sexy therapy. If you're thinking about bed partner or prospective bed partners, hard to prescribe CPAP sometimes. So let's talk about non-PAP therapies, and I'm going to kind of go through in this order here. And the first thing I wanted to emphasize is that there are behavioral changes that people can make. And the biggest one of these is going to be weight loss. And I think that the standard of care for management of sleep apnea has changed over the last 10, 20 years. It's not just about getting people on CPAP. It is also about encouraging weight loss for those who are overweight and obese. So this is a figure from Papard and colleagues. It's old data, but there isn't really anything that's much different. And what you can see on the y-axis is the change in apnea-hypopnea index. And on the x-axis are changes in body weight. And as you would expect, as people gain weight, their apnea-hypopnea index goes up. As they lose weight, the apnea-hypopnea index goes down. If you look at the denominators here for each of these columns, though, you see that way more people gain weight than lose weight. So I think we all know, probably the only thing harder than getting people to use CPAP might be to get them to lose weight too. And so, I want to give you a couple tips on maybe how you can do this. This is one study that Jesse Bacher and Sanjay Patel did where they looked at gastric banding versus CPAP therapy for OSA. This is a really interesting study because it's an RCT and people had to be willing on a coin flip to accept either CPAP or gastric banding surgery. So, these are interesting people that signed up for this. But you can see with gastric banding, people lost, if you look at their weight, they lost about 10 kilos and the apnea-hypopnea index went down from 50 to about 35. So, the main question this leads to, patients always ask, how much weight do I need to lose for this to go away? How much weight do I need to lose to get off CPAP? And unfortunately, we don't know the answer to that question. We don't even know if this relationship is linear, if people lose enough weight and then there's kind of a threshold effect. So unfortunately, we don't know how much weight people need to lose, but just for this example, people lost about 9 or 10 kilos, so about 20 pounds, and they still had severe sleep apnea. So, we're not talking just a few pounds usually, we're talking more than that. As I mentioned, weight loss is something that I think you should focus on in addition to CPAP for obstructive sleep apnea care or any non-PAP therapy. So this study was in the New England Journal about 6 or 7 years ago, and these authors looked at change in blood pressure, let's say, using CPAP alone, weight loss, plus CPAP, and then weight loss. So if you look at 24 weeks here in panel C, you can see that, CPAP and weight loss alone, help your blood pressure a little bit, but much more profound effect if you do both things. And if you look at the right panel, the people who actually stuck with things, look at the drop in blood pressure here, close to 15 millimeters of mercury. So your job as a pulmonary and sleep physician is not just to get people to wear CPAP, it's also to be healthy overall. Weight loss is hard, but as I said, I think the standard of care is changing. So Dave Hudgel was the first author on this clinical practice guideline. Basically, in your management of obstructive sleep apnea, you should also be talking about weight management. I will probably skip over this a little bit, but in terms of thinking about ways to lose weight, in a sleep lecture, it's kind of cool to bring up circadian timing of eating. And so at least in a mouse model, if you eat in line with the circadian phase, that's a lot easier or a lot healthier than eating out of your circadian phase. So there's good animal model data. And, the question is, are people are humans animals too? There are some data that time-restricted eating, similar to intermittent fasting, you can improve weight and weight loss. So these are small studies that are coming out. I love the silhouette here of the man with metabolic syndrome who, after he goes into time-restricted eating, buffs up like Arnold Schwarzenegger. The intervention, though, in this study, for some people is going to be really easy. You just tell people, look, you can eat what you want from like 8 to 6 p.m., but after that, try not to eat as much. And so you can eat what you want. There's no caloric restriction, but at least in small studies, just by doing that intervention, people lose, about 7 or 8 pounds, drops in blood pressure by about 5 or 6 millimeters of mercury. So again, sort of also using sleep medicine to control weight. Okay, so we talked about behavioral interventions. I want to really hammer that weight loss is something that, this doesn't need to be a whole visit on weight loss, but there are some pretty targeted interventions that you can do, even just letting people know that there's a link between obesity and sleep apnea. Some patients don't know that. Just letting people know that if they lose weight, maybe they could be on less CPAP pressure or off of CPAP. These are motivating factors for people. So as we talk about now kind of the other behavioral interventions, and we talk about supine sleep, this is where we start to get into devices. And, when we talk about devices and many of the non-PAP therapies, there is much less data, as I sort of hinted at. And Eric Kazarian, who's an ENT surgeon in Los Angeles, just published this in the Blue Journal. This just came out on Sunday. And the title, as you always try to do with your editorial, is like come up with something clever. So he says, making sense of the noise toward rational treatment for obstructive sleep apnea. And he said that many therapies, that we'll talk about really have limited evidence. The trials are small, they're non-randomized, they're often funded by, the company that's trying to sell something. They operate under the assumption that adherence is going to be better than CPAP. It's very hard to do a true apples to apples comparison for many of these therapies. If you're thinking about surgeries, oral appliances, it's not like there's one surgery, it's not like there's one oral appliance, and different surgeons, different dentists do different things. And again, we often don't have much outcome data beyond the apnea-hypopnea index. So just to give you an idea, here are 3 different therapies to try to keep people off their back. This one is called slumber bump. This is called the REM-T, sort of REM t-shirt. And the idea is that these are physical barriers that prevent you from laying on your back. This is a more high-tech version of your elbow from your bed partner, in that this is a device that you put on your chest. When it senses that you're on your back, it gives you a sort of vibration, tells you to roll over. Again, it's just something that I love is always the advertisements for sleep products. Always a man with a younger wife and things like that, and people smiling during their sleep. Now, this is not that last product I showed you, but it is very similar to that. And what you see here is a true RCT of CPAP versus one of these vibratory positional devices. And this just came out in Thorax this year. And the first thing I would point out, which isn't on this slide, is yes, there were improvements in getting people off their back, and the apnea-hypopnea index did go down a little bit. But the reason I bring up this study is to show some of the adherence and what did people prefer. So again, the idea is that, they call this a convenient vibratory positional device. But if you look at how many hours people use that device per night, it's about 3.3 hours. It's not very high. CPAP was a little bit lower, but it was like high 2s. And the reason there are 2 curves here is that they look at patients who started with the positional device and went to CPAP. So they started with 3 hours, went down to about 2.3. But people who started with CPAP and then went to the positional therapy, they use CPAP pretty well. And when you ask patients, like, which one did you like better? I think a little bit surprisingly, more people preferred the CPAP device. So 60% of the participants wanted CPAP versus 20% for the positional device. So again, you have to challenge the assumptions that non-PAP therapies are somehow more patient favored. Let's talk a little bit about oral appliances. So, and even before we get to the oropharynx, just a quick thing, if you have patients with rhinitis, if their nose is a problem, then you should try to clear up the nose medically. And so Walter McNicholas, an Irish sleep physician, looked at both apneics and snorers, and he just gave them fluticasone for a couple weeks. And in some of these people, you can see dramatic reductions in their apnea-hypopnea index. So that's a very conservative, sort of low-intensity intervention for people that complain of seasonal allergies, nasal obstruction. Now, once you get to the mouth and you talk about oral appliances, again, I just want to emphasize that this is not one device. So, here are just 5 different commonly used devices, and depending on which physician you go to, you will get a different device. So so it's really hard to look at, we don't have a database like the CPAP with 2 million patients. We have, individual individual dentist practices using different devices. So there's variable efficacy, as I'll go over with these devices. Some of that's based on practitioner skill. And it's very hard to predict good response to these devices. And that's something that I'll bring up. People can go through the effort of having impressions made, pay out of pocket for a device like this, and it's hard to predict how they'll respond. We have fewer data looking at outcomes. The other thing is that a dental device is not necessarily a benign therapy. So certainly people can develop headaches or temporomandibular joint discomfort. Over time, the teeth can misalign. You can get some chipping of teeth if you're not careful. So you have to have a dentist who knows what they're doing. I mentioned Peter Sestouli earlier, a clinician in Sydney who has published a lot on this, and Kate Sutherland works with him. This is a great review of oral appliance therapy if you were interested, which was just published in the last 6 months or so. Now, the idea for oral appliances, same as CPAP, is you're trying to create more space for air to go behind the tongue, behind the soft palate. You're using the top teeth as sort of an anchor to pull the mandible forward. And this is an example of the kind of data you would like to have for oral appliances. This is actually a really good study, and we don't have a ton of data like this. So this is from the Blue Journal in 2013, and it's a comparative effectiveness study of CPAP versus oral appliance treatment, and one of their main outcomes was looking at blood pressure. So this is a good study. We don't have enough of studies like this for most non-PAP therapy. Still relatively small, about 120 patients. They made sure that people could tolerate both CPAP and the what they call mandibular advancement device. And then they did a crossover study looking at how people did when they were on oral appliance and when they're on CPAP. And no matter how you look at it, the CPAP was more effective at reducing the AHI. So there's various sort of definitions of responder. But if you just look at the complete treatment response here on the right, with CPAP, you get close to 80% versus complete response in about 40% of those using oral appliance therapy. But as you would sort of hope or expect, maybe compliance was higher with the oral appliance. So here are the numbers here. If you go through the apnea-hypopnea index, with CPAP was down to about 4.5. With the oral appliance, it was down to about 11. But the compliance was slightly higher, 6.5 hours versus 5.2 hours with the different devices. And in both groups, the reduction in Epworth Sleepiness Scale was about the same. If you look at blood pressure, and the closed boxes here are CPAP, the open boxes are the oral appliance. If you don't have high blood pressure, doesn't really do much for your blood pressure. If you do have hypertension, then both groups had about the same, about a 3 millimeter drop in blood pressure from either device. So, thinking about oral appliances similar and how they are effective compared to CPAP, the effective AHI is probably close. Both devices lower blood pressure in those with hypertension. And so the question, though, is which therapy should you try first? And the problem I think that people often have is this variable response with oral appliances. You could go through, go down this pathway, and then the AHI is not that improved. And then the other thing are payer considerations. So for most payers in the United States anyway, things like CPAP are paid for, and most oral appliances you're going to have to go out of pocket. Now, in terms of predicting who is going to respond to an oral appliance, it's generally more mild disease as assessed by the apnea-hypopnea index. If they require a lower CPAP holding pressure, 6, 7, maybe up to 8 centimeters of water as opposed to 20, younger, less obese, and then women do more, have a better response. So this is from that Sutherland and Sestouli review article, which I mentioned. And they say this is the real problem. The uncertainty around the level of AHI reduction achieved following oral appliance therapy has remained a clinical barrier to the implementation of oral appliances in routine clinical practice. And a clinical prediction method has been the focus of much research, but this holy grail remains elusive. I'm going to come back to this when we talk about some more physiology at the end of this. I also would make a plug for the American Academy of Dental Sleep Medicine. This is a website that if your patients are struggling and you need a qualified provider of these kinds of devices, you can go in, put your zip code in, and find local dentists that you can work with. Most dentists claim that they can make some of these devices, but they may have very limited experience versus others whose whole practice might be around this. So I would encourage you to use this website and find someone you can work with. Now, as I was going through my slides this morning, I am totally going to give short shrift to surgical treatment options. I'm really trying to give you a framework of how to think about non-PAP therapies, but the surgical treatment options, there are many of them. The UPPP is probably the most common. And again, the idea here is you're going to cut out as much redundant tissue as possible. There are bigger surgeries. So this is a more radical surgery where you're actually breaking part of the mandible where the genioglossus attaches. You're moving it forward. You're breaking part of the maxilla and creating more space. These are huge surgeries. People look different. This is the kind of thing, if someone undergoes this procedure, their driver's license picture is going to look different. But they have a much greater chance of success with these better surgeries, or bigger surgeries. The predictors of success are the same as with oral appliances. So generally more mild disease, less obese, and they have an obvious upper airway abnormality. So if you have a young, thin woman and you just did not expect them to have sleep apnea and you look in and their tonsils are huge, yes, that is someone that you should consult with your ENT colleagues. And again, I haven't gone into it, but many of the same shortcomings on surgical therapies as with oral appliance therapy. So, that's the oral appliances, that's upper airway surgery. You're generally trying to create a larger or stiffer upper airway. There's few really good trials, and because of that, patient selection, which procedure to recommend, and are different operators having the same outcomes is kind of difficult. So let's talk a little bit about the other sort of gadgets that people have come up with to give you a sort of lay of the land of what else is out there. So these nasal valves were developed by a company called Ventus Medical. It's called ProVent. And these were kind of interesting. The idea here is that these were one-way valves you put on the nose and easy to breathe in, hard to breathe out. And so, those of you who have video on, feel free to do this, or others of you who don't have video on, you can do it. But take a deep breath in, put your fingers in your nose, and kind of try to breathe out through your nose. So I see Dr. Richards doing it. You can feel your tympanic membrane going out. You can feel that expiratory positive airway pressure. So the idea is that you'd create expiratory pressure and keep the airway open. What's interesting here is the valve is not interesting at all. What was really interesting is the company had to develop this adhesive so that it would stay on the nose the whole night, and yet when you take it off in the morning, it no longer has any stickiness, so that you got to buy a new pair every day. Okay, so they charge about $2 for these every day. And as I said, you develop during expiration positive airway pressure. You also would increase end expiratory lung volume, which has some traction on the upper airway and is another mechanism. There were good data for these devices in terms of reducing the apnea hypopnea index, and select patients seem to like it. For many people, though, this causes essentially hypoventilation or sort of auto-PEEP, and many people could not tolerate this. So, there was a tremendous amount of excitement around this kind of device. It is FDA approved, and yet most people would try it and not fill the prescription. This is another therapy which is no longer available, but was FDA approved. So instead of positive pressure through the nose, negative pressure in the mouth. So this is a mouthpiece that sits in the back of the mouth, and there's a little bit of suction here that's applied to this device, brings the tongue and the soft palate forward. I think many of you, or at least have a passing knowledge or know that this exists. This is sleep medicine doctors feeling inferior to cardiologists. So this is a hypoglossal nerve stimulator. And this is a pacemaker for the tongue. So the hypoglossal nerve, or cranial nerve 12, moves the genioglossus forward. This can sits in the chest. There's a sensing lead. And when the device senses that the patient's trying to breathe in, the afferent limb tries to move the tongue forward. Now, this was published in the New England Journal. Pat Strolla was the first author on this back in 2014. And if you look, the data seem, pretty good. So At baseline, you had people with moderate to severe sleep apnea. You get that down to about 7 or so. And if you withdraw the therapy, the sleep apnea comes back. But what really, is what you have to think about carefully with this paper. If you go to the supplement, you can see that in this study of about 120 people, 80 people were considered responders, 40 were considered non-responders. So look at some of these patients here. Their apnea-hypopnea index is 30, and some of them go up to 40. Some people start at 35, they go up to 75. What's going on here? And so it concerns me that you're talking about a surgical implant, very expensive, and a third of patients, even though these patients were carefully screened, they all had body mass indices less than 32. It's concerning that we can't predict who's going to do well with this kind of device. I will say anecdotally, the people that ask you about this are going to be your older, very overweight patients who would never be considered for this therapy, but it is a limitation of this therapy. This always comes up, but the idea that you could train the upper airway muscles in some way, either with a device that electrically stimulates the upper airway or getting people to play a musical instrument. So this study came out some years ago looking at didgeridoo. So this is the sort of Australian Aborigine instrument. And this was a randomized controlled trial where people used the didgeridoo and were able to achieve a lower apnea-hypopnea index. So this is an area of research that has shown small improvements in apnea-hypopnea index or Epworth Sleepiness Scale, but generally pretty minor. I think what's really interesting, this study was done in, I think, Germany, or at least German speaking, so maybe Austria too, and they had to exclude people who had played the didgeridoo already. I didn't realize that it was as popular that you would not be able to enroll subjects. Okay, so again, I wanted to give you a little bit of background on sleep apnea, review how good CPAP is, and give you, what are the other things that are available, or at least some of the things that are available besides CPAP. And I just want to spend 5 minutes on another way to think about sleep apnea pathogenesis and how that could help us predict how we could personalize therapy, essentially. So I showed you this slide before, and I said that anatomy was really the biggest factor when we talk about having obstructive sleep apnea. And I kind of went over some of the other factors, but now I want to just let you know that different people have different effectiveness of their muscles at night. Different people build up their respiratory effort at different rates when they're asleep and they have obstruction, and different people are easier or hard to wake up. And so, for a long time, the group in Boston that I was part of, David White, Atul Malhotra, and Andrew Wellman, have sort of thought about sleep apnea not just as an anatomical problem, but some of these other non-anatomical issues. And so, whether or not your muscles work, loop gain is a term for ventilatory stability, and then how easy or hard you are to wake up. And so this was our model or our thought for a long time. It turns out that the model's slightly different. So anatomy is the most important. So if you have an airway that is always going to be open, you're never going to develop sleep apnea. If you have a BMI of 60, no matter those other non-anatomical traits, you're always going to have sleep apnea. But there are a group of people, and in fact, probably the majority of people with sleep apnea, who their anatomy could go either way. Their airway is a little bit collapsible, and these other factors play a role, either protecting people from sleep apnea or condemning them from sleep apnea. And this is just to give you an idea. So we actually can measure the collapsibility of the upper airway, and we use a term called the P-crit, or the closing pressure of the upper airway. And I'm not spending great time on this, but if you have a very collapsible airway, if you need 5 centimeters of water to keep the airway open, you're always going to have sleep apnea. On the other end, if you have to suck on the airway with negative pressure of 5 centimeters or more, these people never have sleep apnea. But there is this overlap where the anatomy is the same, and some people have no sleep apnea, AHI on the x-axis. Other people have AHIs at 80. And so, this is just an example that different people have sleep apnea for different reasons, and these different reasons are often non-anatomical traits. And so if you can measure these things in people and understand why an individual has sleep apnea, it might help you target therapy. And so we have drugs that will change the arousal threshold. We have medications that will change the ventilatory control, like Diamox or oxygen. And we might even have medications that will stimulate upper airway muscles during sleep. So this is a study by Danny Eckert, where he gave Lunesta. And if you took patients who woke up too easily and gave them Lunesta, their apnea-hypopnea index went from 25 down to 11. If you didn't have an arousal threshold problem, if that wasn't the reason you had sleep apnea, the drug didn't really do anything for you. Here are two different studies. Brad Edwards, now down in Melbourne, at Monash University, he gave oxygen, so affects control of breathing, and a sedative to let people stay asleep, and he could help obstructive sleep apnea. Andrew Wellman's lab still is looking at this, where they gave drugs that would help keep sort of the muscles on during the night. Again, showed great reduction in obstructive sleep apnea. Now, none of these things that I'm showing you are FDA approved for these indications. I'm just showing them to you to give you a sense of where the field is going, and we need some of these, we need better understandings of the pathophysiology to target therapies. We looked at how some of these other non-anatomical factors would predict surgical outcome. So Sylvia Lee did a postdoc with us. She's an ENT surgeon in Beijing. And just one thing, if you're thinking about improving the upper airway in some way, whether you use an oral appliance or whether you do surgery, it kind of depends where you're starting at. So if you have a horrible anatomy and you do some surgery and it makes the anatomy a little bit better, that's not enough to open the airway. If you have a pretty good anatomy, you're at point A here, and you do something to improve the anatomy even more, you're doing great, But there are people that the anatomy, even if you do a procedure, is still going to be in this vulnerable region, and these non-anatomical traits play a role. And I won't go into the details, but we could better predict who was going to have resolution after surgery when we took into account things like control of breathing, how easy or hard somebody would wake up. The last thing I'll say is that we talked a lot about adherence today, and there is some data that people who wake up too easily are the ones that can't use CPAP. And so, if you could focus those intensive efforts at adherence, either with CPAP or oral appliance, you could do that by understanding the physiology. Skip over this slide. And the last thing I'll say is that we've been very interested in looking at the waveform. So I don't know how many of you have looked at sleep studies, but all through the night you're looking at the inspiratory flow patterns. And here's a sample from 9 different patients. And what I would tell you is that some patients look kind of like a flat top. Other people have a little snoring. Other people do some funky stuff here. And the idea is that maybe this is giving you information about what part of the upper airway is collapsing. And if you could correlate these flow patterns with anatomy, you could know what you need to cut out, for example. So Pedro Henta looked at this, and this is an interesting study. He did natural sleep endoscopy and was looking at where different things collapsed and looked at the flow patterns. And there's at least some preliminary data that you can localize the site of collapse. So I will summarize by saying that obviously anatomy is the underlying problem, but I think in the future there's some exciting stuff to come because there are non-anatomical factors that are important. PAP works, the adherence is getting better, and I think for many patients, CPAP is going to be your first-line therapy, but either because patient wants to try something else or you think they're a good candidate for other therapies, there are other options there. It's just very hard to predict who will respond, and that's really, as Peter Sestouli mentioned, going to be the holy grail. So I think I will stop there. If there are other questions that people have and they want to ask me offline, there's my email. So thank you very much for the opportunity to speak today.
Awesome. Thank you so much, Dr. Owens, for a wonderful talk. And we will open it up to the group. If you have any questions, comments, need for clarification about any aspect of this presentation, please either raise your hand or put your comments into the chat so that we can ensure that we address any points of contention or need for clarification. In terms of moving forward, oh, please.
Oh, no, go right ahead. I just wanted to take the director's prerogative and ask a question or two.
Please do so, Dr. Scher. We appreciate your prerogative.
Okay, so this was a masterful presentation, Robert. Just an excellent overview of this field, which has so much more work left to be done in it, as you've noted. I just want to mention 2 things. One is Another thing about, aside from the the number of responders in the hypoglossal nerve device, the other interesting thing about that is that, at least for the first one that was approved, it was almost predominantly male subjects, and I kind of always thought that women were too smart to do this, but showing my bias. But I wondered why that was, because there wasn't anything about the anatomy that should have predicted that you would have males only. And you know, I mean, women do pacemakers and stuff, but it was so disproportionate that I wondered if anyone's had any insights into that since.
Not that I know of. You know, what's interesting is that I think that the company certainly had much more aggressive projections about sales for this device. And in the 6 years or so since it's been FDA approved, you know, they're only still at about, I think, 4,000 to 5,000 implanted worldwide, most in the United States, but it's still relatively few. As you noted, there was nothing in the inclusion or exclusion criteria. You know, there was nothing that said that it had to be men. And yet that's sort of who signed up. I would, you know, to be honest, speculate a little bit about who is willing to have a device in their body that might be, you know, potentially visible. That's the only thing I can think of, is that it was just, you know, some disparity about, you know, who would consider having this. Yes, there's more people, more men typically have obstructive sleep apnea, although women catch up after menopause. So, yeah, I'm not sure that is very interesting. I guess I would say I just think no one has looked at that much since then, because the numbers are still relatively modest at this point.
And the second question that I had, which relates less to devices than how we look at success. Of course, sleepiness is an ongoing issue, but the other aspect is the relative importance of the ODI compared to the AHI. And again, studied more in CPAP than in, probably not studied very much in anything else. Do you have any preference for what you would like to see as the standard ODI or AHI or something else as a metric of success?
Yeah, I sort of deliberately, you know, avoided, I mentioned that there are different definitions for sleep apnea, and I think in the sleep field, I think there is a real, it's a real problem that we sort of have differing definitions of what is sleep apnea. The only thing I would say, kind of related to your point, is that, you know, I don't only look at the AHI when I consider who I might put on non-PAP therapy. If I have someone who has a relatively modest apnea-hypopnea index, and yet their oxygen nadir is quite low, you know, there's something else that makes me think, you know, this person needs a little bit more lung volume and a therapy that is definitely going to get their oxygen saturation a bit higher. I do take that into consideration. But as you could gather from my answer, I'm not terribly scientific about it, but I do consider oxygen desaturation separately from the AHI when I sort of consider what therapies for management.
Thank you. Jeremy?
And so, Dr. Owens, we have one question from a participant, Mohanad, who says or asks, is there any recommendation for patients who take off their mask at the end of the night due to high pressures, despite the fact that the download data, the pressure data that you get, doesn't really reflect that the pressure is all that high? How do you deal with or interpret that kind of situation?
Well, a couple thoughts come to mind. I mean, certainly it's a common clinical scenario that people come back and they're only using CPAP 4 or 5 hours per night, and they say, well, I wake up and it's on the floor or whatever, or
right.
the pressure is quite high. I think that there are two general approaches that I would say. The first is that you could limit the CPAP pressure. So certainly if you have an adjustable PAP, you know, you might turn down the maximal pressure and go for something that's 95% effective or 90% effective as opposed to 100. And so I've employed that with success at times. The other thing I'll mention, which I should have mentioned in my talk, but these therapies may not be mutually exclusive. And so I have patients who use CPAP, and then when they travel, they put in an oral appliance. I have people who use oral appliance and position therapy, or use position therapy so that their CPAP levels can be a little bit lower. So for this kind of patient, I would say, hey, maybe try sleeping more upright, get a wedge pillow, sleep on your side, and then you won't necessarily need as high a pressure. Some people do use oral appliances and CPAP. I think that's a lot to ask people to wear, but some people do things like that to get the pressures down. Again, if your patient is overweight or obese, that's the long-term health and long-term proposition is that, you tell them, hey, if we get your weight down, the CPAP pressure comes down. And with the newer technologies, you can actually, show people, here's your 90-day download. And look, your pressure is actually coming down slightly as you've been losing weight. So I think that's the kind of positive reinforcement I try there. So anyway, there's a variety of approaches. I don't think there's one answer.
Awesome. Thank you so much for going through that in terms of thinking about reducing pressure, encouraging lifestyle changes, and thinking about sort of adjuvant interventions with regard to oral devices or other considerations. So, Dr. Owens, thank you. We appreciate your expertise.